So this research was supported by a microelimination grant by Gilead Sciences Canada. So although we know that the majority of HCV infections occur among people who use drugs, who inject drugs, treatment uptake in this group has historically been quite low. Estimates around 5 to 13% are pretty common. And so despite the recent advances in Hep C treatment, and there persist many barriers to healthcare engagement for people who are currently injecting drugs. Lack of trust with the healthcare system, as well as past negative experiences, difficulty completing pre-treatment workups, including venipuncture, and high rates of loss to follow-up between initial testing and treatment initiation all impact treatment uptake. So supervised consumption sites are places as places of HCV care haven't really been well researched at this point in time. A recent research review of Gray and academic literature uncovered few studies of point-of-care testing within HCV, of HCV point-of-care testing amongst people who use drugs generally, and only one study of point-of-care HCV testing within a supervised consumption service. HCV testing and treatment is mainly mentioned in theoretical terms as a potential linkage, and a survey result published by the Drug Network of Drug Consumption Rooms said that of the 51 DCRs worldwide, the current practice tends to refer people for HCV treatment off-site as opposed to being able to do on-site testing. About 75% of sites refer off-site, and treatment is only done in about 4% of drug consumption rooms. In 2015, for a bit of a Canadian context, a community pop-up clinic provided HCV point-of-care testing outside of Insight in Vancouver. So people who know the Lower East Side in Vancouver know that there's a high concentration of services for people who inject drugs within a very small neighborhood geographic setting. And this study that was done in Vancouver ended up finding that even though these services existed literally 1 or 2 doors down, the pop-up testing was able to identify new HCV cases and people who are willing to engage in HCV treatment. So it shows that there is the importance of locating programs within spaces that people are currently utilizing. So in the past year and a half, supervised consumption services and overdose prevention sites have been expanded across Canada. And supervised consumption acts as an extension of harm reduction services aimed at reducing bloodborne infections and preventing overdose, connecting people who use drugs to health and social services. SCSs also model a non-judgmental, low barrier and supportive space where people using the service are often encouraged to partner in creating environments that are comfortable for them to access. They also offer a potential opportunity to engage people who use drugs into HCV care. And an obvious benefit of point-of-care RNA testing is that this eliminates the loss to follow-up that happens during standard public health 2-stage testing. Not requiring venipuncture seems to be something that's important for some people, but for others, it doesn't really seem to make much of a difference. So our study was to basically look at the feasibility of offering HCV point-of-care testing and subsequent linkage to care among service users of an integrated consumption service in Toronto. So people who are eligible to be part of this study are people who are using the supervised consumption services at Keep 6 in South Riverdale and were not currently on active HCV treatment. Repeat testing was done every 3 months for a year to evaluate HCV transmission dynamics, including HCV prevalence, incident infections among those who were negative, and phylogenetic analysis to determine relatedness. And this presentation provides a preliminary data on the feasibility and uptake of these services. So one of the important things about this study is actually the setting. So South Riverdale Community Health Centre is located in Toronto's east side and has been around for nearly 40 years in their current location at Queen and Carlaw. The east end of Toronto is home to a variety of income earners and is a culturally diverse population. As most other community health centers, there's an interprofessional team of service providers, including physicians, nurse practitioners, social workers, counselors, health promoters, community workers. It goes on and on. We do food stability, housing access, as well as primary care. And South Riverdale has been providing comprehensive, innovative, and responsive harm reduction to the community for the past 20 years. It's one of the city's largest needle and smoking or STEM distribution programs in the city, and one of the city's only harm reduction programs that have specific programming for women. There's an ongoing commitment within South Riverdale's harm reduction program to have staff who are working and coordinate the programming who have current or former experience of using drugs. So the Toronto Community Hep C program is co-located within South Riverdale Community Health Centre, and the supervised consumption services have existed there since 2017. The supervised consumption service is known as Keep Six, and it can be found right off the lobby doors, I think. No, never mind. I thought I might have a pointer ability, but I'm not going to be able to figure that out quick. Just off the lobby doors right there. So it's right out front and easy to access for people. So beginning in mid-August of 2018, we started offering testing 3 days a week to service users of Keep Six. The supervised consumption service can accommodate 4 to 5 injection or consumptions at any one time, is staffed by a nurse, health promoters, and people with lived experience of using drugs. To be eligible, participants could not currently be on Hep C treatment and had to be registered service users. So we were really trying to eliminate, people hearing about the testing and walking in from the street because it's a fun new. It's kind of like, when you saw the drone take off, everybody got really excited about it. It's the same kind of thing. You end up having a new testing model and everybody gets excited about it and people wanted to come in and do testing. So we really tried to limit it to just people who were actively injecting within Keep Six and were registered service users. So the testing platform used was the Cepheid RT PCR platform, which requires a finger prick blood sample and provides results within 60 minutes. Questionnaires were administered at baseline to collect demographic, current access to health or testing, and nature of drug use. If participants were agreeable, an additional blood sample was done on blotter cards for dried blood spot testing, basically as a way for us to be able to test the test. And finally, people who connected to the treatment team for Hep C treatment and ongoing care also had a serum sample for phylogenetic testing obtained. So testing was advertised by posters in the consumption room, and compensation was offered to participants. And we definitely did benefit from word of mouth amongst people in the community. And that little white box right there is the Cepheid Gen Expert. So that's the size of the lab in the supervised consumption site. So initial outcomes. So we are one person away from being able to meet our target of 125 study participants. The last is always the hardest. So we initially thought we would take about 12 months to engage participants. And so we've been able to do 126 service users agreed to participate in 9 months. Oh, sorry, 2 of them, no. Yeah, well, that's where we are. 2 of them later were removed for ineligibility. One was actually currently on Hep C treatment, which we learned later on, and one was not currently injecting, so hadn't been a member of the supervised consumption service. In those who tested positive for Hep C, 77% were men, 87% reported unstable or no housing, as compared to 73% in the general population of people who joined up into the study. 83% injected drugs daily, as compared to 68% in the total sample. More than half of the people recalled being tested for Hep C in the past, but of those, less than half knew what their status was. They often said they didn't know if they had a detected viral load or what testing had been done for them previously. 28 people who thought they had received RNA testing, only 5 knew their results. One mentioned, I didn't stay for the results, so I don't know what the results were. Also, a number of people ended up saying that they had been tested in prison, and the reporting of results back to them it didn't happen. So in addition to the confusion around testing, there was different reports or messaging on who was eligible for treatment, oftentimes related to the changing nature of coverage in Ontario, but also related to dated information on interpretation of results, like your viral load is too low or you don't have elevated enzymes, so therefore there's no fibrosis and you don't have to worry about it. Language still persists in the community about nascent or dormant HCV infections. We often hear concerns about people regarding treating people who are actively injecting drugs around reinfection. So in our sample, 10 people had previously completed HCV treatment and they remained negative during this treatment, and the SVR results had been at least a year ago in order to qualify for the study. One who had received 4 days of interferon in prison had obviously remained Hep C positive. So preliminary results, we had a large number of invalid tests at the very beginning of testing. Some of this may have been because of inadequate blood samples, and because the sample is 100 microliters and in a tiny little pipette, any clotting that happens within the blood can end up leading to a sampling error. We also had a shipment of cartridges that malfunctioned, so we got a new shipment, and those seemed to work a little bit better. Of 112 valid tests, 41% were RNA positive, which is pretty much on track with the iTrack data that's previously been published for Ontario. 17, so 30% of those people have started additional treatment assessments and are connected with our hepatitis C treatment group. 4 treatments have started, with 1 treatment completion in SVR. There were 2 deaths of individuals who were part of the study during the course of the study. There were 4 seroconversions, so because we're doing serial testing every 3 months, we found 4 seroconversions so far out of 36 individuals. So we know that supervised consumption services in and of themselves are not enough to prevent HCV infection. And I think in having conversations with the individuals who have seroconverted, it's not so much around sharing needles. It is a lot more about sharing cookers, so what people are cooking drugs in. And a lot of that has to do with the unavailability of drugs, and so people using whatever they can use to not be sick. And I know that I've run out of time. So just like early challenges and lessons learned, word of mouth referrals really ended up helping us out with this. The pre and post-test counseling by supervised consumption staff extended past the period of time when somebody is first given their diagnosis, which makes sense. People take a little bit of time to digest and process things. So having a group of individuals who are able to have ongoing conversations is obviously very helpful. Ongoing access to the treatment nurse within the SIS was helpful, but what really ends up helping individuals engage are staff at the SCS who have lived experience of Hep C and have gone through treatment programs as well. Treatment uptake has primarily been limited by the need for 6 months evidence of chronicity, so a lot of these people are individuals who have not been tested before, and so we haven't been able to start treatment on the majority of individuals who we have tested positive. And unexpected benefits include the increased use of supervised consumption and engagement in healthcare beyond Hep C treatment. So interest in the point of care testing was high. I think we have about 125 people who end up using the supervised consumption site on a monthly basis, maybe a little bit more, 130, with about 5 to 10 new people per month. So we're getting pretty good coverage of the group of individuals who use this small-scale supervised consumption site. And point-of-care testing seems to be a way of being able to help people connect within integrated Hep C treatment programs. I think that idea of context disruption may end up being helpful in the way that we're thinking about this here. Thanks.